Assalamualaikum warahmatullahi wabarakatuh and a very good morning to everyone. Ladies and gentlemen, distinguished guests, colleagues and viewers joining us from all across the region, a warm welcome to IMR-SEAMEO Webinar Series 2026. The theme today is Rare Inherited Metabolic Disorders in Malaysian Children, from Diagnosis to Molecular Insights. Our presenters today are from the Institute for Medical Research in Malaysia. I am Dr. Firdaus, chemical pathologist from Biochemistry Unit under the Specialized Diagnostic Center of IMR and will be the moderator for today's session. Before we proceed with today's session, I would like to briefly introduce on rare inherited metabolic disorders, also known as inborn errors of metabolism or IEM, and the role of Biochemistry Unit under the Specialized Diagnostic Center here at the IMR. Just a brief introduction to IEM. It is a rare genetic or inherited disorders in which the body cannot properly turn food into energy or clear out toxic waste. It is usually caused by a missing or defective gene in specific proteins, often the enzyme, causing enzyme deficiency that disrupt the normal process of the human body. The overall incidence of the IEM is about 1 in 2,500 of live birth, and it affects all races worldwide. It is categorized as a rare disease, and IEM usually affects babies and children, but also can occur in adulthood. What is a rare disease? A rare disease is a condition that affects a small percentage of the local population. There are approximately 6,000 to 8,000 rare diseases worldwide. Malaysia defines a rare disease as a medical condition that affect less than 1 in 4,000 people. Almost 500 rare diseases in Malaysia have been recognized to date by the Ministry of Health. 72% of rare diseases are caused by genetic factors. 70% of patients are children, and 30% of patients die before the age of 5. We do acknowledge and observe Rare Disease Day. It is an official international awareness raising campaign that takes place on the last day of February each year. This year in 2026, Rare Disease Day is celebrated with the inspiring theme, More Than You Can Imagine. The main objective of the campaign is to raise awareness among the general public and decision makers about rare diseases and their impact on patients' life. We have to know, behind every rare disease diagnosis is a story of resilience, and this theme serves as a powerful reminder that while individual conditions may be rare, collectively they affect millions of people worldwide. Next, let's move on to our center, a Specialized Diagnostic Center or SDC. SDC consists of 5 units, including Biochemistry Unit, Endocrine Unit, Special Protein Unit, Molecular Diagnostic Unit, and lastly, Specimen Management Unit. The Biochemistry Unit serves as a national referral laboratory specializing in biochemical genetics and inherited metabolic disorders. The unit provides highly specialized diagnostic services involving more than 85 specialized tests for screening, confirmatory testing, and disease monitoring for patients from Malaysia and neighboring countries including Indonesia and Brunei. Our unit focus on the diagnosis of various metabolic and rare genetic disorders, particularly neurometabolic disease, lysosomal storage disorders, and other inherited metabolic conditions through advanced and high-end laboratory technologies. Among the specialized technologies used include tandem mass spectrometry, high-performance liquid chromatography, gas chromatography mass spectrometry, high-resolution electrophoresis, spectrophotometry, and enzyme assay platforms. These methods support early diagnosis, accurate disease confirmation, and better clinical management for patients with inherited metabolic disorders. Apart from providing diagnostic services, the Biochemistry Unit is also actively involved in research, biomarker discovery, method development, and innovation to further strengthen metabolic disease diagnostic and precision medicine in Malaysia. It also serves as a national training center for Master of Pathology postgraduate and a national site for subspecialty training and special interest attachment in genetics and IEM. We do also provide comprehensive training program for masters, bachelors, diploma students, and laboratory personnel across Malaysia and neighboring countries. I think that wraps up our unit introduction. We would like to invite further collaboration with all the participants joining us today. Ladies and gentlemen, this webinar series was initiated with the aim in mind to share knowledge, discuss topics on biomedical research, and present research outcome. Before we begin the presentation, allow me to announce a few housekeeping messages from the Secretariat. We will not be taking questions during the presentation, but participants may post their question using the link shared in the YouTube channel. The Q&A session will be conducted after both presentations have ended. An attendance link is also provided in YouTube channel for those who would like to receive an e-certificate of attendance. Lastly, please subscribe to our National Institute of Health Malaysia YouTube channel and click for notifications whenever there is a new post. Ladies and gentlemen, for today's webinar, we have two distinguished speakers. Let me introduce to our first speaker, Dr. Hamizah binti Idrus, who is a medical officer in the Biochemistry unit under the Specialized Diagnostic Center of IMR. She obtained her medical degree from Manipal University in 2014. Throughout her career, Dr. Hamizah has been actively involved in clinical biochemistry, biochemistry diagnostic, laboratory quality management, and research. Her research area of interest include inherited metabolic disorders and specialized biochemical diagnostic with particular focus on homocysteine analysis, glycosaminoglycan and high-resolution electrophoresis screening for mucopolysaccharidosis, oligosaccharidosis screening, and urine sialic acid analysis. She has presented and published her work nationally and internationally, including award-winning related to her research in biochemistry. For today, Dr. Hamizah will be sharing her research experience with the presentation titled Hyperhomocysteinemia and Homocystinuria in Malaysian Children, Diagnosis, Management, and Clinical Outcomes. Dr. Hamizah, the screen is yours.
Assalamualaikum and a very good morning everyone. Thank you Dr. Firdaus for the kind introduction. I'm Dr. Hamizah from the Biochemistry Unit, Specialized Diagnostic Center, IMR. Today I'll be presenting about hyperhomocysteinemia and homocystinuria in Malaysian children in the context of diagnosis, management and clinical outcomes. I hope this presentation will provide practical insights into these rare metabolic disorders and their relevance in clinical practice. So this is an overview of today's presentation. Then let's begin with hyperhomocysteinemia. Hyperhomocysteinemia refers to an elevated plasma total homocysteine concentration, which includes free, protein-bound, and disulfide-bound form. Its causes can be broadly divided into three groups. The first is genetic, involving inherited defects in enzyme responsible for homocysteine metabolism. The second is nutritional, resulting from deficiencies of folate, vitamin B6 or vitamin B12, or occasionally excessive methionine intake. The third includes secondary causes, such as chronic kidney disease, hypothyroidism, and pernicious anemia. Importantly, elevated homocysteine is not simply a laboratory abnormality. It is recognized as an independent risk factor for cardiovascular, cerebrovascular, and thromboembolism. Therefore, identifying the underlying causes is essential as treatment varies depending on the real diagnosis. Then, what is exactly homocysteine? Homocysteine is a sulfur-containing amino acid that is not obtained directly from the diet. Instead, it is produced during methionine metabolism and serves as an important intermediate in the methionine cycle. Under normal physiological conditions, plasma total homocysteine ranges from 5 to 15 micromoles per liter. Values between 15 and 30 are considered mildly elevated, 30 to 100 moderately elevated, and above 100 represents severe hyperhomocysteinemia. When homocysteine accumulates, it becomes toxic to multiple organ systems. And elevated homocysteine levels indicate disruption of methionine metabolism, especially within the remethylation and transsulfuration pathways. Both pathways depend on essential cofactors including folate, vitamin B6 and vitamin B12. Either cofactor deficiencies or inherited enzyme defects can lead to homocysteine accumulation. With that background, let's look at how these pathways normally function. Homocysteine sits at the intersection of two important metabolic pathways, like I said, remethylation and transsulfuration. Let's start with methionine. Methionine is an essential amino acid obtained from dietary protein. After participating in methylation reactions, it is converted into homocysteine. In remethylation pathways, homocysteine is recycled back into methionine by methionine synthase using vitamin B12 as cofactor and 5-methyl tetrahydrofolate generated by the MTHFR enzyme as the methyl donor. Alternatively, in the transsulfuration pathways, homocysteine is converted into cystathionine by CBS enzyme, which requires vitamin B6 or pyridoxine. When defects occur in CBS, MTHFR or other enzymes involved in this pathway, homocysteine will accumulate. Although all these disorders share elevated homocysteine as common features, each of these diseases will produce distinct metabolic profile and clinical phenotype. So today's presentation will focus on 4 diseases identified in our study. The first is CBS deficiency, also known as classical homocysteinuria. It is caused by pathogenic variant in the CBS gene, resulting in deficiency of cystathionine beta synthase enzyme. The second is cobalamin C disorder. It caused by pathogenic variants in the MMA-CHC gene, resulting in deficiency of MMA-CHC protein, which is a cobalamin chaperone involved in intracellular vitamin B12 processing. This disrupts the synthesis of both methylcobalamin and adenosylcobalamin, which are essential cofactors for other metabolic reactions. The third is MTHFR deficiency, caused by pathogenic variants of gene with the same name, leading to reduced activity of methylene tetrahydrofolate reductase enzyme and impaired remethylation of homocysteine. Finally, congenital vitamin B12 deficiency results from defect affecting vitamin B12 absorption, transport or cellular uptake, including genes such as transcobalamin 2 and gastric intrinsic factor. Next, we look at how these biochemical abnormalities translate into the clinical features observed in our patients. 3 key biochemical disturbances are responsible for the most of the clinical manifestation. First, elevated total homocysteine. It causes oxidative stress, leading to endothelial injury and neurotoxicity. Then this mechanism contribute to intellectual disability, seizures, and thromboembolism. Homocysteine also disrupt connective tissue integrity by impaired the collagen cross-linking, resulting in features such as atopia lentis and Marfanoid habitus. Second, reduce methionine. It also reduces the production of S-adenosylmethionine or SAM, the body's principal methyl donor. This results in hypomethylation, impaired myelination, and abnormal brain development. This results in neurodevelopmental impairment and hypotonia. Finally, elevated MMA or methylmalonic acid causes mitochondrial dysfunction and reduce ATP production, leading to energy failure. As a result, patient may develop encephalopathy, hypotonia, and acute metabolic decompensation. Together, this mechanism explain why this disorder affect multiple organ system. Then we have to look, before we look at the Malaysian data, we have to look into the rare disease in globally. CBS deficiency has estimated prevalence of 0.38 per 100,000 populations. However, the highest reported incident is approximately 1 in 1,800 live births among the native Qataris, largely attributed to founder effect and consanguinity. For cobalamin C disorder, the estimated incident is around 1 in 100,000 live births, based mainly on expanded newborn screening programs in North America and Europe. MTHFR deficiency is even rarer, with fewer than 250 cases reported worldwide, and its true prevalence remains unknown. Importantly, this estimate varies with population characteristic and screening practices. At present, Malaysia has no population-based prevalence data, highlighting the need for greater awareness and further local research. And this brings us to the motivation for our study. Although these disorders are increasingly recognized worldwide, comprehensive pediatric cohort data from Malaysia and Southeast Asia remain limited, with most published evidence originating from other countries and continents. To address this gap, we conducted this study to better understand these disorders. Specifically, we reviewed the clinical manifestation, the biochemical profiles, molecular findings, the treatment approach and clinical outcomes of the affected children. To answer this question, we performed a retrospective observational study. Eligible patients were first identified through the lab records, after which their clinical information was retrieved from the clinical request form and clinic follow-up records and the lab information system. The collected data will then reviewed and analysed descriptively. Patient selection was based on our selective high-risk screening program involving 96,000 patients screened between 2010 and 2022. And we included children younger than 18 years old at diagnosis with significant hyperhomocysteinemia, defined as homocysteine exceeding 40 micromoles per liter. And for the diagnostic investigation done, all biochemical investigation were performed at IMR Kuala Lumpur, the National Referral Lab for Inherited Metabolic Disorders. 4 complementary metabolic investigations were performed. Rather than relying on single biomarker, this investigation provides comprehensive biochemical profile. I'll briefly introduce each investigation. So the first investigation is dry blood spot, then the mass spectrometry, performed using flow injection analysis. The key analytes were propionyl carnitine, or C3, acetylcarnitine, C2, C3 to C2 ratio, and amino acid methionine. Together, these markers are useful for identifying disorders of propionate and cobalamin metabolism. The second investigation is urine organic acid analysis, performed on random urine sample using gas chromatography mass spectrometry, or GCMS. The key metabolite of interest is methylmalonic acid, or MMA. Next is plasma amino acid analysis, performed using ion exchange chromatography with post-column ninhydrin detection. Among the amino acid measured, methionine is particularly valuable because it helps differentiate between these disorders. And in cases of severe hyperhomocysteinemia, free homocysteine can be detected. Lastly, plasma total homocysteine, which is measured using high-performance liquid chromatography with fluorescence detection. In addition to specialized metabolic testing, routine investigations included full blood count, vitamin B12 and folate measurement to identify the nutritional deficiencies and associated hematological abnormalities. For the molecular confirmation, genomic DNA extracted from the EDTA blood samples and then followed by targeted sequencing of the CBS, MMA, CHC, and MTHFR genes. The identified variant then analysed using specialized bioinformatics software and classified according to the internationally accepted interpretation guidelines. With the diagnostic approach established, let's now examine the characteristic of the patient that we identified. A total of 16 patients were identified, and the largest group comprised of remethylation disorder, accounting for 56% of the cohort, including 7 patients of cobalamin C disorder, 2 with MTHFR deficiency. CBS deficiency represented 31% of the cases, while congenital vitamin B12 accounted for the remaining 13%. Based on the screening cohort also, the detection rate of inherited hyperhomocysteinemia was approximately 0.01%, reflecting the rarity of this disease. One of the most striking findings also that we found is the age at the diagnosis. Patient with CBS deficiency diagnosed much later with mean age of 9 years old, whereas patient with cobalamin C disorder were diagnosed at 1 year old, more than 1 year old at average. And those with MTHFR deficiency before 1 year of age, along with the congenital B12. These differences reflect the natural history of the disease. Remethylation disorder usually present during infancy with severe neurological symptoms, prompting for earlier medical attention. So earlier the diagnosis and also treatment. In contrast, CBS deficiency often develops more gradually, resulting in delay recognition and diagnosis. As a whole, our cohort, they highlight the predominance of remethylation disorder. Then now examine the clinical presentation. Across all 4 disorders, neurological manifestation were the predominant presenting features. The most common findings included developmental delay, learning disability or intellectual disability, hypotonia or hyperreflexia, seizure or status epilepticus. However, each disorder also demonstrates its own characteristic clinical profile. First, with CBS deficiency, they appear presented later in childhood with a classical phenotype like Marfanat habitus, ectopia lentis, intellectual disability, and one patient had thromboembolic complication, specifically superior sagittal sinus thrombosis. And cobalamin C disorder, they presented during infancy, less than 1 year, mostly, and they have symptoms like developmental delay, hypotonia, feeding difficulties, and respiratory complication. One patient also presented with thromboembolic complication. Patient with MTHFR deficiency presented even earlier during the first few months of life. Their clinical course was more severe with respiratory failure, require mechanical ventilation, together with status epilepticus, hypotonia, and hyperreflexia. Congenital B12 deficiency showed a more variable severity, but commonly presented with hematological abnormalities and developmental delay. Overall, clinical presentation differs depending on the underlying diagnosis. However, severe hyperhomocysteinemia carries a high risk of thromboembolism. Regardless of the cause, an early diagnosis is the key to achieve better long-term outcome. Now let's look at the biochemical findings. Although elevated homocysteine observed in every patient, the combination of the homocysteine, methionine, and methylmalonic acid or MMA clearly distinguish the underlying disorder. Methionine was markedly elevated in CBS deficiency only, reflecting impaired transafferation. In contrast, it was low in the remethylation disorder because methionine regeneration was impaired. Then methylmalonic acid further differentiated the cobalamin C disorder and congenital vitamin B12 deficiency from CBS and MTHFR because MMA remain not detected. Looking at the treatment response, at the chart of the treatment response trend, plasma total homocysteine decreased in all disease group, demonstrating all overall positive biochemical response. However, the greatest improvement was observed in congenital B12 deficiency, where homocysteine returned to normal range following treatment. This finding reinforced the role of homocysteine as the primary biomarker for diagnosis and treatment monitoring also. While methionine and MMA are essential for identifying the underlying defect. Then we move to the molecular findings. I will just briefly highlight of our molecular findings. Overall, our study demonstrated considerable genetic heterogeneity across 4 disorders. In CBS deficiency, we detected 6 pathogenic or likely pathogenic variants, including 3 potentially novel variants. However, there is no clear genotype-phenotype correlation was observed. For cobalamin C disorder, we found that C.609G2A variant was the most frequent mutation in our Chinese patients, and it is also a recognized hotspot mutation in early onset cobalamin C population. Most variants were predicted to produce truncated or absent MMA-CHC protein. In MT-HFR deficiency, we identify 2 potentially novel variants predicted to impair enzyme function through protein truncation and nonsense-mediated mRNA decay. Although these variants remain unclassified, they warrant for future functional validation. And for the congenital BTF deficiency, there is no pathogenic variants identified despite compatible clinical and biochemical findings. So this reminds us that negative molecular result does not exclude the diagnosis, and future reanalysis may also reveal the currently unrecognized pathogenic variants. Overall, this finding, they tell that we have the knowledge of non-molecular spectrum of this disorder in Malaysia, and highlight the importance of molecular testing for accurate diagnosis. Then we move to the treatment approach. Although management differs between disorders, the therapeutic principle, they divided into 3 main goals: to reduce homocysteine, to restore methylation, and to correct the methionine deficiency when present. Mechanism of the treatment is straightforward. Pyridoxine especially will enhance residual CBS enzyme activity in responsive patient, while methionine restricted diet reduce substrate load. Betaine provide alternative free methylation pathway by acting as methyl donor. Hydroxycobalamin and folic acid support remethylation, whereas methionine supplementation corrects methionine deficiency. As shown in the treatment matrix, different combinations were used according to the underlying diagnosis. Hydroxycobalamin, folic acid, and methionine supplementation primarily used in remethylation disorder, whereas dietary methionine restriction and pyridoxine used in mainly CBS deficiency. Betaine were commonly prescribed. However, we must say that despite the availability of the effective therapies, long-term metabolic control was often limited by poor adherence, particularly to strict diet restriction and painful regular injectable treatment. Then we will look now at the long-term outcome. Clinical outcome is different among 4 disorders and will strongly influence the timing of treatment initiation. Patients with CBS deficiency had poorest long-term outcomes. Many continued to experience ophthalmological complications, learning difficulties, and thromboembolism. Largely due to delayed diagnosis and prolonged exposure to the homocysteine and methionine, and challenges in maintaining their metabolic control. For patients with cobalamin C disorder, generally have better outcomes, reflecting their earlier diagnosis and treatment. However, there still be residual neurodevelopmental impairment remain common, probably because neurological injury begins before or shortly after birth. Patients with MT-HFR deficiency continue to experience severe neurological disability, including seizures, spastic motor dysfunction, and neuro-ophthalmological abnormality. In contrast, congenital vitamin B12 showed most favorable prognosis with resolution of hematological abnormalities and normal cognitive motor development following treatment. Then, this is my key take-home message. To summarize, our study demonstrates that these disorders are rare but clinically heterogeneous. Remethylation disorders, particularly cobalamin C disorder, represented the largest group in our cohort, and neurological manifestation were the predominant clinical manifestation. Although treatment improved biochemical control, early diagnosis, timely intervention, and good long-term adherence remain the most important determinants of the clinical outcomes. Before concluding, I would like to acknowledge several limitations of this study. First, the small cohort size limited disease-specific comparison and genotype-phenotype analysis. Second, some patients had incomplete clinical data due to the retrospective study design. Third, patient recruitment was based on selective high-risk screening, which introduces selection bias and does not reflect the true disease burden within the Malaysian population. As a result, several important research questions remain unanswered, particularly regarding genotype-phenotype correlations and the true prevalence of this disease in Malaysia. Moving forward, prospective multi-center collaboration together with future expanded newborn screening program may allow a larger cohort to be studied and improve understanding disease epidemiology, long-term outcomes, and optimal management. That brings me to the end of my presentation. I would like to express my sincere gratitude to everyone who contributed to this study. My heartfelt appreciation goes to the staff of Biochemistry Unit and Molecular Diagnostic Unit, Specialized Diagnostic Center, Institute for Medical Research for their invaluable support, collaboration and dedication through this project. I would also like to thank our clinical collaborators from Department of Genetics, Hospital Kuala Lumpur and Hospital Pulau Pinang for their partnership in patient diagnosis and management. This work would not have been possible without the close collaboration between laboratory and clinical teams. The findings presented today have been published in Clinical Biochemistry, and I hope they will contribute to improve the recognition and diagnosis of these rare metabolic disorders, particularly within our region. Please feel free to scan the QR code to access for full publication. If you have any question or are interested in future collaborations, you are most welcome to contact me via the email address provided. With that, I would like to conclude my presentation. Thank you so much for your attention. I'll be happy to take any question.
Thank you, Dr. Hamizah, for the interesting talk. If there are any questions that you would like to ask about her presentation, kindly submit your questions using the link provided in YouTube channel. Next, I would like to introduce our second speaker for today, Dr. Mardhiah binti Masri. Dr. Mardhiah is a chemical pathologist at the Specialized Diagnostic Center of IMR. She obtained her medical degree from University Kebangsaan Malaysia in 2013 and later completed her Master of Pathology in Chemical Pathology at University Technology Mara. Throughout her career, Dr. Mardhiah has been actively involved in clinical biochemistry, biochemistry diagnostic, laboratory quality management, research, and also innovation. Her research area of interest include inherited metabolic disorders and specialized biochemical diagnostic with particular focus on high complexity and labor-intensive diagnostic testing using high-end gas chromatography mass spectrometry instrumentation. Her work focuses on specialized biochemical genetic and inborn errors of metabolism investigation include urine organic acid profile, plasma organic acid profile, and urine succinyl acetone analysis. She has presented and published her work nationally and internationally, including award-winning related to her research in biochemistry. It is our great privilege to have Dr. Mardhiah here with us to share her research. Her presentation title is Rare Disease, New Discoveries, Understanding Isolated Methylmalonic Acidemia in Malaysian Children. Over to you, Dr. Mardhiah. The screen is yours.
Thank you, Dr. Firdaus, for the very warm and kind introduction. Assalamualaikum and a very good morning, everyone. Thank you to the organizer as well for the opportunity for me to share my work. My name is Dr. Mardhiah binti Masri from Biochemistry Unit Specialized Diagnostic Center. Today, I'll be presenting our work on rare disease new discoveries, understanding isolated methylmalonic acidemia in Malaysian children. So this presentation is meant to be educational, so I'll just not focus on the results, but more to the clinical findings, biochemical and molecular finding, and how they can be integrated into practical diagnostic workflow. So these are my outline of presentation. Go first to the background and pathophysiology of iMMA, the study objective and methodology, followed by the results and discussion, and finally the key message and conclusion of this study. So first of all, what is isolated methylmalonic acidemia? It's a rare autosomal recessive metabolic disorders caused by mainly defects in the mute gene or methylmalonic CoA mutase enzyme, or it can also be caused by the cobalamin or B12 metabolism genes, for example, MMAA, MMAB, MMADHC, or MCEE. So when these defects occur, it leads to the accumulation of methylmalonic acid, which will become toxic to baby, and baby can be presented in such a very wide clinical spectrum. Some babies can present very early with severe metabolic crisis, for example, metabolic acidosis, hyperammonemia, poor feeding, and some may present a bit later with milder presentation, for example, developmental delay, seizures, or failure to thrive. So we can see that patient may have very broad clinical manifestation, and the diagnosis may be a bit challenging in this broad presentation. So if we look here at the illustration, this shows the positions of Malaysia within Asia Pacific context. So we can see that as we look at the figures, this is only the estimated regional prevalence, in which it shows that Malaysia has slightly higher prevalence as compared to the Asia Pacific and other regions. But this figure should be interpreted cautiously, because this may not represent the true burden, because the true burden may be underestimated by the nationwide newborn screening percentage, or may be affected by the sample population for each study, and also may reflect population specific numbers. Okay, so we shouldn't interpret the figures based on the numbers itself, but we should interpret it more like population aware interpretation. And as we know already, it is rare globally, so low frequency condition require refined data, and it should be interpreted in a very complete context. So in this perspective, Malaysia still shows a higher prevalence as compared to other regions. So this figure highlights the metabolic pathway, what's going on during IMA. So to simplify it, let's imagine about the production line, right? So in MMA, usually, normally, the methylmalonic CoA will be converted to succinyl-CoA. So we can see here, it should be converted such way lah. So when there is a deficiency of enzyme, for example, in MMUT enzyme, which defects in this MMAA or MMAB gene, or defect in this main enzyme, MCM enzyme, methylmalonic CoA mutase. So this conversion, this normal conversion will not be happen normally. So it will cause the methylmalonic CoA to be increased, causing the methylmalonic acid accumulated. So when this accumulation happens, it becomes toxic. So it will be manifested as a metabolic acidosis, as well as will result in the mitochondrial dysfunction and energy production failure. So these consequences will be manifested in the baby with the clinical presentation of the severe metabolic crisis, like metabolic acidosis, hyperammonemia, and many others. So this table highlight the importance for us to distinguish between iMMA versus combined MMA. Because why this is important? Because iMMA and combined MMA has a different defect and also slightly different presentation. So the key diagnostic clue in these two distinguished condition is that the one of the lab clue is the homocysteine level. So in isolated MMA, usually the homocysteine level is normal. In combined MMA, usually it is associated with increased homocysteine level. So we can see that both cases associated with increased methylmalonic acid. And the IMA, usually the defect is mainly on the methylmalonic acid metabolic pathway only. But in combined MA, it involves as well the homocysteine pathway. That's why leading to the increased level of homocysteine. Methionine in IMA usually normal, but in combined MA can have significantly elevated, as presented by Dr. Hamizah about the cobalamin disorders related to it. And the genes affected in both disorders also differs. You can see that IMA have mainly caused by MMUT, but in combined MA, they have different causes of genes that can be involved. For example, MACHC, MADHC, as well as the rest. And clinical presentation, in IMA, the clinic usually presented with metabolic crisis, but in combined MA, they have much more systematic presentation, because other than the metabolic crisis, the affected baby also can have neurological involvement, hematological, and thrombotic features. In terms of management as well, they differ significantly because IMA require different approach of treatment. For example, protein restriction, carnitine, and emergency metabolic care. While in combined MA, they require hydroxycobalamin and other form of treatment, for example, betaine, folinic acid, and protein management. So the key clue here is to determine the homocysteine level, one of the lab clue, to differentiate whether this patient has IMA or combined MA. So there are three important research gaps in my study that I want to highlight. Firstly, limited local data. Yes, as we know, rare disease usually have limited access to local data, and very few Malaysian cases reported locally. So, and secondly, we still have lack of local variant databases without comprehensive Malaysian IMA variant registry. So with this limitation, it may contribute to difficulty for us to interpret, especially the molecular interpretation. And we also have limited long-term outcomes data, for example, pertaining to the patient response towards treatment, the survival, as well as the clinical outcome. So this scarce and very limited data will limit the significance of the study. That's why we conduct this local study to address this gap and hopefully can improve the diagnosis and enable precision care and guide us towards future therapies for Malaysian patients with IMA specifically. There are two main objectives in this study. Firstly, to characterize the clinical, biochemical, and genetic features of IMA in Malaysian children, and secondly, to identify the underlying disease-causing variants to improve diagnosis and management. So, this study is basically a retrospective study carried out in IMR between January 2020 until 2024. So we have included patients suspected of IMA from hospital across Malaysia, provided that this patient has been molecularly confirmed IMA from the molecular testing. Other than that, we also evaluate the biochemical screening in which we included those with show increase in propanil acylcarnitine C3 as well as increase in C3 to C2 ratio. And other than that, we also evaluate the finding from urine organic acid analysis, for example, the methylmalonic acid and the methyl citrate, and the Sanger sequencing also being conducted to further confirm the pathogenic variants. And there are also additional assessment done in this study, mainly B12 responsiveness testing and also the structural protein modeling that will be discussed in my upcoming slide. So the focus is to identify the clinically suspected patient and genetically confirmed IMA cases. So we can see here that we have included total of 7 patients molecularly confirmed IMA, and most patients diagnosed during the neonatal period. So the age at diagnosis range between day 1 to 6 years, but most of them are presented at neonatal period. We have male predominance and majority of them are IBAN. And we look at the clinical features. So we can see that common clinical features include metabolic acidosis, hyperammonemia, encephalopathy, and sepsis-like illness. Again, I want to highlight the early onset cases usually presented with severe metabolic crisis, and the late onset usually milder presentation with neurological presentation, for example, seizures. And the key biochemical profile, they have consistent finding with increased C3, increased C3-C2 ratio, and increased urinary methylmalonic acid with normal homocysteine, which further support the diagnosis of isolated MMA and to differentiate with the combined MA. So looking at this finding by cases, so we can appreciate that the cases has variation in terms of timing and as well as severity. And as I mentioned earlier, most of the cases presented early at the neonatal onset, and most of them presented very severe metabolic crisis, and one presented during infancy time, and one case presented late childhood. So across the cohort, all of the patients show consistent biochemical finding consistent with the diagnosis of IMMA. And what we can see here is that despite the variation of the clinical presentation, we can still rely on the biochemical finding to support the diagnosis of IMMA, again highlighting the importance of the role of biochemical as well as the molecular role to confirm the diagnosis of IMMA, despite the variable or variation in the clinical presentation and the timing of the onset of the disease. So now we look at the biochemical and clinical outcomes in this cohort. So they shared consistent biochemical finding across the cohort, and we also perform B12 responsiveness testing in this patient, and most of them non-responsive. I will explain later. And when we look at the outcome data, the clinical outcome, if patient has been followed up biochemically, they show variable biochemical outcome. So some case 1, you can see that patient improved biochemically, case 2 partial improvement, and case 5 worsen. And there are also cases that defaulted and lost the follow-up that we cannot detect the biochemical response. So what I want to highlight here is the clinical outcome. 3 cases alive with 2 cases had mild learning disability. So from case 1, 2 and 6, actually case 1 and 6 detected early, especially case 2, in which this case benefited from the high-risk screening, or we call pre-symptomatic screening, as the patient has positive families history of MMA. So, and also case 1 and 6 also detected earlier. That's why highlight the importance of early detection, because it will affect the clinical outcome in this patient. And in this case 3, 4 and 5, unfortunately passed away due to multi-organ failure and decompensation. So these 3 cases, most of these cases presented at the very early neonatal onset, and I have highlighted that early onset disease has severe presentation. So it reflected by the very significant outcome, and we can say that early onset IMA very likely associated with significant mortality. So now we go to variant findings in Malaysian IMA cohort. So from this total of 7 patients, we have 7 distinct variants, and most of the cases is among MMUT related diseases, and only 2 patients are MMAB related disease. So importantly, we identify 2 novel variants which identified in case 1, and this novel variant expand the local IMA mutation spectrum. So from this expansion of this knowledge, it will not only benefit our local data, but also for the use of global understanding of IMA. Now I'll explain a bit about B12 responsiveness testing in IMA. Why does it important in this cohort? So why do we test B12 responsiveness testing? Because we want to identify whether this patient responsive towards B12 or not, for us to guide treatment and prognosis. So the protocol here done bedside at the hospital site by administration of hydroxycobalamin at specific days, and after that sampling will be done according to this protocol. And then we will see at the result. Responsive patient is the one who had more than 50% fall in methylmalonic acid or reduction in related metabolite, for example, homocysteine. And non-responder, patient will show no significant biochemical improvement. So why it matters? Because the responder one will benefit from the B12 therapy and usually show better prognosis, whereas in the non-responder cases, as we have observed in most of the patients in this cohort, they are non-responder, most of them. So they require another approach of management, which includes stricter dietary management like protein restriction, and we have to manage them with appropriate metabolic care. So we don't have to give B12 for this kind of group of patients. So now we will dive into this advanced modeling, but I will just brief in a simple way for us to understand and appreciate this approach. Okay, so why this modeling is important and can give additional input and value. So this basically is a supportive evidence. So we now know already that IMMA can be diagnosed based on clinical suspicious, biochemical finding, and as well as confirmatory by the molecular, right? So from this finding, we can further understand the underlying mechanism and where is the exact location of the any changes in the protein, or where is the underlying defect in the enzyme function. So we will analyze the selected variant, usually the variant of interest or novel variant. So in this study, we analyzed these two novel variant, and using specialized software tools, we will then can predict the potential underlying mechanism, whether this is likely damaging or to further support the pathogenicity of the novel variants. Okay, so the key takeaway from this modeling is that both novel variants are located in the important region of the mute enzyme, and structural modeling predicts that the novel variant impair the enzyme or the protein function. So this will be further support the findings of the novel variant. Just to highlight that this interpretation of protein structure modeling require correlation between clinical, biochemical, as well as molecular confirmation. It shouldn't be interpreted only on its own, but it should be correlated as a whole, integrated as a whole. So now I come to part of discussion. So at this stage, we know that the early onset is common in this cohort. You can see by the summary of the cases, and most of them present a very severe presentation. And IMMA can mimic sepsis. So this, for example, with poor feeding, tachypnea, metabolic acidosis, we can also see these features in neonatal sepsis. So that's why clinical suspicious should prompt metabolic investigation accordingly based on clinical finding. And the biochemical profile is key for diagnosis. For IMMA, the elevated C3, C2 ratio, and as well as the homocysteine level will support the diagnosis for IMMA. And also the molecular confirmation is crucial and important to provide the subtype classification and to further support the genetic counselling as well as the prenatal assessment, and also for sibling risk assessment. And the identification of novel variants further expand the local knowledge and adds to the Malaysian IMMA mutations spectrum locally, and also for global understanding of IMMA. And we have also identified possible e-bind population clustering, but this require further multi-center studies with larger sample to further confirm this population specific trend. So in conclusion, Malaysian IMMA cases mainly severe and with neonatal onset. Molecular testing strengthen and support the diagnosis, and the newborn screening improve early diagnosis and can improve the outcome. So before I end, I would like to acknowledge the clinical, laboratory and molecular genetic teams who have involved in this work. And this reflects that in any rare disease studies or work is a shared effort requiring at the stage of clinical suspicious, timely testing at the lab level, and close communication between all teams. Although rare diseases are uncommon, their impact on health or the impact on each child and family is life-changing. So as Malaysia advances in newborn screening and genomic medicine in the future, this kind of local data will be very meaningful and essential to improve diagnosis and patient care. Thank you very much for your attention. I welcome any question from the audience.
Thank you, Dr. Mardhiah, for the insightful presentation. We will now be moving to Q&A session. please do not hesitate to send us your questions using the link provided in the YouTube channel. And I will try my best to connect you to our distinguished speakers through the posted questions. Nevertheless, should the time not allow us to address all the questions, our speakers will try their best to answer the questions through email. Okay. It seems that we have received a few questions from our audience. I think for the tight time, possible for each speaker, we will have one question each. Yeah. Okay. First question to Dr. Hamizah from Dr. Siti from UPM. In your experience, what are the major challenges encountered in diagnosing homocystinuria in Malaysia, particularly in cases with atypical clinical presentation or delayed referral? Over to you, Dr. Hamizah.
Thank you, Dr. Firdaus, and thank you for the question from Dr. Siti. For the diagnosis of homocystinuria, if specifically classical homocystinuria, the challenges would be in getting the clinician to have the awareness about homocystinuria and then requested for the testing. As the clinical features for homocystinuria is very unique compared to the other disorder of like hyperhomocysteinemia in general. So in terms of symptom, the features would be not so confusing or misleading, as most of the patient will show significant or unique symptoms like Mardhiah habitus and atopia lentis. And in terms of diagnostic investigations, before treatment, they usually will show markedly elevated homocysteine and methionine. So in terms of challenges in diagnosing early, it depends heavily on the clinical suspicion. However, in terms of other diseases like hyperhomocysteinemia, like remethylation disorder, the diagnosis will be more challenging if the level of homocysteine will be moderate level, like 30 to 100. Because if the patient sample that sent to us was only plasma homocysteine, we cannot diagnose the patient based on homocysteine alone. So the clinician should send sample other type of sample like urine, organic acid, or plasma amino acid to get the correct diagnosis and to complement the homocysteine findings. In terms of secondary causes, if the patient showed atypical biochemical presentation, like only homocysteine is raised, the clinician we should suspect that patient have secondary causes for hyperhomocysteinemia. So I would say the challenges will start from the symptoms, the clinical presentations, and what to send to the lab, and what testing should be done, and then we can further confirm the diagnosis by molecular. I think that we answer my question.
I hope that response was helpful. Yeah. Okay, let's take one final question from the chat before we wrap up. The question would be to Dr. Mardhiah. How do you ensure the variants in your case study were novel?
Thank you, Dr. Firdaus, and thank you for the question. So in this study, we have 2 novel variants. So the confirmation will carry out or confirmed by checking at the international genetic databases. We have few, one of it like HGMD and GenomeD and many other databases. So as well as we also look at the published literature, for example in PubMed. So these are among the sources that we need to check before we can conclude that these are the novel variants. And from at this point, even though the variant is tagged as novel, not necessarily is disease-causing variant. So therefore, we need to further evaluate it by referring to other guideline. For example, the established ACMG guideline, and together with other information, we also correlate with clinical information, biochemical information to further determine it's really novel. And novel meaning that it has not been reported yet in any of the sources that I've been mentioned previously.
Thank you to our panel. I trust that information clarifies the queries raised. I'm afraid that is all the time we have for the Q&A session. Any additional question will be answered by speakers through email. We hope that this webinar has shed light on some research work that we have conducting in IMR and will spark interest and could initiate research collaboration with others. Ladies and gentlemen, now we have come to the end of the webinar session. I would like to thank all participants for their support to make this session successful. Don't forget to subscribe to our National Institute of Health Malaysia YouTube channel. Before I conclude, I would like to announce that we will have the next session of IMR-SEAMEO Webinar Series on 31st July 2026. So mark your calendars. The theme for the next webinar is Extreme Temperature and Health, Ensuring a Safer Future for Communities. We hope you can join us at the next session. Until then, many thanks from all us at IMR. Take care and stay safe.